Well, healthcare remains a top issue and a top concern for Canadians, despite years, decades even, of promises and lip service from political leaders to fix the system. Wait times, in particular, remain a huge problem for healthcare in this country. Our next guest has spent years trying to change all of that. He has been at the forefront of the national conversation now for decades. Dr. Brian Day is founder of the Cambie Surgery Centre. He's also an associate professor in orthopaedic surgery at UBC, past president of the Canadian Medical Association, and he is the author of an important new book. It is called My Fight for Canadian Healthcare, a 30-year battle to put patients first. Dr. Brian Day, so great to have you with us here. Welcome to the program.
Thank you for having me.
Let's talk about what prompted you to write this book. And when you're sort of reflecting on all of this, it does sound like maybe is this sort of a new chapter for you? Is in some ways a step back from the fight?
Well, no, actually, it's a step forward because, we have, for many years, we've tried engaging with politicians. That didn't work. And then we've tried going the legal route, and that didn't work. And now the position that I've taken is it's up to the public. So here we are in Canada with, which is on the scale of countries, a rich country. And if you look at groups like the Commonwealth Fund, for decades, we have been ranked highest or near highest in cost of countries that have universal healthcare, and at the bottom of the 10 highly developed countries that have universal healthcare in terms of access to care, in terms of the access to technology, access to surgery, access to a family doctor, and things are getting worse. So the position I've taken now is it's up to the public to understand that change is necessary, and we're not talking, which is what opponents like to portray, about privatizing, quotes, the health system. We're just talking about introducing a little bit of competition, the way countries like Sweden and Norway and Denmark and Germany and Switzerland, these are not right-wing radical countries.
Right.
I don't think most of your viewers would know that there is only one country of the almost 200 countries on the planet where private health insurance for health services is illegal. And
Mhm.
we're in it. That's how bizarre
Yeah.
the situation is. And, the position I've taken for years is that no monopoly serves the consumer well. By definition, they don't. They're out. They don't need to.
Yeah, there are a lot of myths that we believe about our healthcare system, right? There's almost like a lot of kind of legend in enshrining the healthcare system that maybe we don't understand, or especially those maybe who don't get stuck on waiting lists or have encountered that side of the system that maybe people don't appreciate.
Yes, well, what it's gotten to the state now where just recently a report came out showing that 35,000 patients. This is just based on less than half of the provinces, so it's probably double this. Less than so about 35,000 patients in those provinces that were reviewed based on government data die every year waiting for healthcare procedures on a wait list. They die on a wait list. And, a cynic would say, well, that's saving the government a lot of money because what the government has done, governments actually, because we don't have a single government system. We have 14 ministers of health and 14 ministries, which are the reason why we have this massive bureaucracy. And what the position the governments have taken is that we can promise healthcare, we don't have to deliver it, and at the same time, so that we don't look bad, we're going to make it unlawful for you to get private health insurance. Well, no country in the world has done that except Canada.
I mean, the system's never been perfect, but as we sort of go back to when maybe this all began for you, and as you talk about in the book, it's maybe around that period, right in the late '80s into the early '90s, where you really started to notice a deterioration.
Yes, I mean some of the actions that were taken by government. If you if you look into the history of the early '90s, even that's when experts, quotes, economists advised governments, and the governments swallowed their argument, that the cause of rising health costs was the fact that we were training and had too many doctors and too many nurses treating too many patients, and that was costing a lot of money. So they closed and cut back. They closed nursing schools, cut back medical schools by up to 30%. And guess what? We now have a shortage of doctors and nurses.
Yeah.
This is the level of stupidity, if you like, that governments believed and acted upon in the 90s. And when I came to Canada in the 70s, there were no problems. We were between second and fourth in the number of doctors per population. Now we're around in the world on a population basis. We're now around 70th. And this is through government policy. It's through nothing but government policy. The other thing is, of course, we have a monopoly. Talking about monopolies, we also have an unusual government monopoly on medical schools. So they control the flow of doctors, and whereas in other countries, even countries like Britain, but in the United States, which is our closest neighbor, medical schools like Harvard and Yale, Stanford, Columbia, these are non-government schools. These are not second-rate medical schools, and they're training doctors. We need to train more doctors, and if the government won't do it, then we should be looking for alternatives.
Let's talk about why you started the Cambie Center. What you saw as maybe a need for that or a void to be filled. What was the motivation
Yeah.
there?
So, when the government when we lost our recent case at the BC Appeal Court, they they came out with statements that were shocking, and I think they were deferring to the higher court, the Supreme Court of Canada, which, in a cowardly manner, in my view, refused to hear the case, even though they heard a similar case and granted the rights we were seeking to
Yeah.
Quebecers in 2005. But what happened is that we, as surgeons in the public system in the late 80s, were being told that we couldn't treat patients. So the average in my specialty, the average orthopedic surgeon, and this is data from the Canadian Orthopaedic Association, requires 13 and a half hours a week of operating time just to maintain competence. That's like, an airline pilot needs a certain number of flying hours to maintain competence. We
Mhm.
were progressively cut from about 20 hours a week down to 5 hours a week. And in my case, I had 400 patients waiting to get into hospital. That frustration led a group of us to look at we're basically taking the position, if the government won't let us into their hospital, let's consider building our own hospital. And our main target back then was injured workers. One of the other strange paradoxes in this country is that many groups are exempt from the laws that
Right.
forbid access to private care. So the workers' compensation boards across the country, they are privately funded by employers, and they want to get patients back to work because it costs them money um, not to. And so our main target early on was injured workers and similar exempted groups. One of the strange paradoxes also is that there are many exempted groups in Canada, exempt from the rules, including groups like judges are exempt.
Right.
So judges are allowed to access private insurance. Um, the armed forces, strangely enough, any federal employee, but also included in that is our federal prisoners. So,
Wow.
we kind of sarcastically said we're trying to get the same rights for Canadians who are not in jail as those that are in jail, that those in jail have. And so our motive was we were being denied access to surgery, and I was in charge of. I was actually chair of the National Committee on Test Committee for Orthopedics, and I was also chair of the local UBC Training of Orthopedic Surgeons academic program. Of 16 young orthopedic surgeons that we had trained over a 4-year period, only 5 remained in Canada because they couldn't get work here, because rationing was the approach of governments. And the BC Appeal Court, despite ruling against us, they, the startling statements they made in their ruling were that wait lists are caused by deliberate government rationing of access to care, which is a policy they've taken to ensure fiscal sustainability of the system. They also said and confirmed what I mentioned earlier, that Canadian patients are suffering and dying as a result of this. Yet, despite that, they ruled that it's not our. They basically took the position it's the job of politicians. So, you know, politicians have given up. The court system has given up, and so the book is an attempt to persuade patients that they need to make their politicians accountable for this. So Canada now, one of the statistics that is most profound is that the lowest income groups in Canada have the worst access in Canada. So we are actually, if you look at the top 10 countries, developed countries that have universal healthcare, we are the worst in access, and particularly the worst in access for low-income Canadians. So it's absolutely not doing what we do. And I kind of use the sports analogy. If you were looking at, if you were the coach of a sports team, and there was a league of 10 teams, and you were at the bottom, wouldn't you, and you were spending more than those at the top, wouldn't you look at what the top 2 or 3 teams were doing and try and implement some of those measures? And we're not doing that in healthcare.
I want to go back to something you said, and it sort of almost speaks to what we were talking about earlier, and these myths or these comforting myths we believe about our healthcare system. I think one of them is the idea that we don't have a two-tier system, that for whatever its flaws, we don't have two-tiered healthcare in Canada. But that's not really true, is it?
It's absolutely not true. One of the chapters in the book is on hypocrisy, and in the late 90s, I wrote an op-ed article called "The Hypocritical Oath," and the fact is that as we all know, politicians and people in power don't wait. We historically, well, at our own clinic, we've had 2 leaders of the NDP treated privately. We were in the courtroom a few years ago, taking on the defendant in the trial is known as the Attorney General, the Office of the Attorney General of British Columbia. During the trial, they were sending us patients privately. That office. We were the instigator of the court action that forced us to go into court was the BC Nurses Union. They were sending us private patients, their staff members. This is the hypocrisy that goes on. Individuals, and these are all in the public record, individuals like Jean Chrétien, Robert Bourassa, Senator Ed Lawson, lots of well-known politicians have gone privately, many to the U.S. And this is not about rich versus poor. My planned fixes include the introduction or the legalization of private health insurance. And as in Switzerland, I lived and worked in Switzerland for 6 months. What you do to eliminate that concept of rich versus poor, what the Swiss do is, for the low income groups, they pay the private insurance premiums. So actually, low income Canadians get the same private health care that wealthy Canadians get. So it's just that there's a means test. And, so obviously Conrad Black would not get supplemental private health insurance. He'd pay the whole shot himself, and he'd probably be happy to do that. But the low income groups get subsidized private health insurance. And then they have, as I said, federal politicians are all exempt from these rules. as our judges and so on. So it's to me it's very the hypocrisy is a defining feature of our healthcare system.
So, how do you respond to the critics then who make the argument, and I guess we can also point to other countries, but make the argument that if we allow private insurance or allow private clinics more access to Canadians, that it's a drain on the public system, and the public system ends up worse off as a result as doctors go to the other side.
It's absolutely the reverse. That we know, for instance, in our own clinic, we have about just over 100 doctors, and 23 of them are younger surgeons who have said, if it were not for the extra operating room time that they have here, they've been given like 5-6 hours a week in the public hospital, they would not have a viable practice, and they would have gone to the United States. And
Hmm.
2,000 Ontario nurses, I don't have the figures for every province, commute every day down to the United States to work.
Yeah.
Reason? They can't get full-time work in Canada. As the BC Appeal Court said, the government is deliberately rationing here. We don't have a shortage of orthopedic surgeons. There are 3,500 young Canadians also going to medical schools outside of Canada because the government won't train enough. These are false accusations, and they have no basis in logic or fact. And the opposite would happen. That we need to. The other thing we need to do is honestly is we do need to um, address the fact that family physicians are underpaid. I mean, I kind of joke in a way, but you know, family doctors used to do house calls.
Right.
Nowadays, nowadays they can't sustain it because most family doctors are running a practice. They've got an office and overhead, and the 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 government fee for a house call for a family physician is one quarter of what a skilled trade person would get for coming to your home. And I kind of said, we've got to we should be training our medical students how to fix locks and do a bit of plumbing so they can justify going and doing a house call. It's really this rationing of is part of, and to maintain fiscal sustainability. That's what the BC Appeal Court said, not me. Um, is part of the problem that we don't have enough funding to to look after Canadians. The other things that happen: 200,000 Canadians go abroad every year to get healthcare.
Hmm.
2 million Americans go abroad every year to get healthcare. So, sorry, 2 million Americans. That's not 2 million Americans go abroad every year to get healthcare. This is the quotes business called medical tourism. They are going and paying for surgery in other countries. We are the United States' biggest trade partner, yet none of those 2 million Americans come here. If we opened our hospitals on evenings and weekends and didn't close the ORs at 3 o'clock in the afternoon and treated those individuals, this is a worldwide business now of medical tourism, we could be generating massive revenue to support the public system. And this is out there. So even in quotes communist Cuba, um, they treat non-residents and use the revenue to improve and bolster their public health system. We should be doing the same. This is, the British do it at the hospitals in London, especially, and they generate revenue. They use that money to subsidize the public system, and there are many other deficiencies that we have, but the bottom line is this is an economic disaster, healthcare. We are mortgaging our youth. We are borrowing, as you know, we're now $1.4 trillion in debt in Canada. The interest on that debt alone is more than we spend on healthcare. We are creating this debt, putting a mortgage on the next generation, on our youth, and that's not right. And people of my age, the older baby boomers, are now starting to hit this health system like it's never been hit before, and it's going to get worse. And we need to come up with solutions. The problem with governments is they only work on 3 to 4 year financial cycles. When I was you need to think long term. When I was Canadian Medical Association president, we carried out an economic study on just 4 procedures in Canada. And the economic cost of waiting for just 4 procedures, so we're talking about loss to the economy from workers not being work of all types, not just workers' compensation, was $14.8 billion in 1 year in 4 provinces. This is massive revenue. Now this is a cost that we are not addressing. We're just letting the debt pile up. And the point of that study was to show that it's actually more expensive to keep people waiting to the economy. And we should be treating people quickly, because it's not only better for their health, it's better for the economy. And that's the logic on which workers' compensation boards across the country use private facilities, because they don't want that kind of debt. They're responsible for the economic costs. The other strange paradox, I said earlier, we don't have a single health system. We have 14 ministries of health, which creates a massive bureaucracy. For every public health bureaucrat that Germany has on a per capita basis, Canada has 11. We have 60 in BC alone. We have 64 vice presidents in health authorities, probably each earning over $500,000 a year, shuffling paper. I kind of joke that how come our BC health authorities need 64 vice presidents when the United States can manage with one? This is a massive bureaucracy draining the public system. And the other, perhaps the strangest thing of all, is that when you cross a provincial border, you are exempt from the rules. So,
Yeah.
so to give you an example, a short while ago, I was treating at the Cambie Surgery Centre. I was treating 5 Albertans, while a colleague in Alberta was treating 6 British Columbians. This is bizarre. Like, this is crazy. And I kind of use the analogy. How would you feel? You're in Ontario. How would you feel if Quebecers or Manitobans were allowed to come into Ontario and drive through red traffic lights and speed at 100 kilometers an hour because the laws don't only apply to you? That's the strange and peculiar paradox that we have in healthcare.
I do want to touch on the legal side, and you talk in the book about your own challenge in the courts and the Supreme Court decision 2 years ago to not hear your case. But we also had, of course, the Chauli decision from the Supreme Court, which was hugely consequential. So this gets to the whole issue of charter rights, Section 7, and the suffering caused by wait times and the rationing and the lack of options. But given how the Supreme Court has dealt with these two cases, are we in a bit of a kind of muddled picture now?
Well, we absolutely are, because as you know, in the Supreme Court of Canada, in the Chauli case of 2005, they ruled that to allow Canadians to suffer and die without any safety net is a violation of their rights, and therefore they legalized private health insurance. Our case was seeking the same rights for Canadians who don't live in Quebec as the Supreme Court of Canada granted to those that do live in Quebec. And what we they actually didn't turn us down. They refused to even hear the case, despite the fact that the BC Court of Appeal had said Canadians, BC residents are suffering and dying on wait lists, and this is a deliberate government strategy. And the other thing the BC Court of Appeal said was, we do not wish to indicate that we are condoning this health system. It's just that it's not our role. And this is passing the buck to politicians, passing the buck to the Supreme Court of Canada. And the Supreme Court of Canada, in a cowardly way, refused to even hear the case. A case that they had ruled, a similar case that 20 years ago they had ruled that Quebec was violating the charter rights of Quebecers. They didn't want to consider whether a similar right should exist for non-Quebecers. It's bizarre.
Yeah, that's disappointing.
And the Supreme Court of Canada judges should be ashamed of themselves. And that I've heard 8 or 9 judges that I've talked to say that about the Supreme Court of Canada.
So where do we go from here? You alluded to this at the beginning. Maybe it's up to Canadians to be the ones to demand change. But where do you see this issue going?
So I think we need, I think politicians need to read this book. They need to understand how that we are unique. There are ways to improve the health system by introducing some market principles. One of the cures, if you like, is to legalize, introduce a bit of competition. In Germany, 10% of the public have private health insurance. 90% are covered by the public system. I had recently a German visitor, an orthopaedic surgeon, and I asked him, what are the wait lists for a hip and knee replacement like in Germany in the public system? His answer was, they're very long compared to the private system. I said, well, how long? He says, maybe 3 or 4 weeks.
Wow.
And that's what, and it was only 1 or 2 weeks in the private system. So
Right.
The whole point is introducing some competition. The other thing we're unique in the OECD in exclusively funding our hospitals with global budgets. That means every year, the hospital region in Canada is given its budget up front, and therefore every patient that goes to an emergency, every patient that has surgery is using up the hospital's budget. So the last thing the chief financial officer of a hospital wants is patients, because they are cost items. In every other developed country that has universal health care, and every OECD country, a patient goes to a hospital for, say, a hip replacement, the public system pays the hospital, whatever it is, $15,000, $20,000. Therefore, the chief financial officer wants patients. The other thing that other countries do is a healthcare guarantee. We know that the government has data on the maximum safe acceptable times to wait, and they're not meeting those benchmarks by any means. For instance, we had data in our trial in 2017 from the government that we had to bring a hostile witness to get, because they keep it secret. Only 16% of patients with a serious bladder cancer likely to spread were being treated in the maximum safe time. With a healthcare guarantee, what you do is you say, as you approach that maximum acceptable time, the government is forced legally to pay for you to have that treatment elsewhere, privately or publicly.
Mm-hmm. Well, the book is out now. It is called My Fight for Canadian Healthcare, a 30-year battle to put patients first. Dr. Brian Day, thank you so much for joining us here today. Appreciate the conversation.
Thank you.